Complete versus partial hydatidiform. Mole hydatidiform mole is a classic high-yield GTD topic, and the exam usually asks one thing: complete versus partial. In this video, we'll lock the distinction using 3 pillars you see here: clinical clues, genetics, and histology with p57. If you can connect these 3, you can solve most MCQs and Viva questions on molar pregnancy. Where it fits: GTD first. Place it on the GTD spectrum. Hydatidiform mole is part of gestational trophoblastic disease, and the spectrum you must remember is mole to invasive mole to choriocarcinoma. That's why the diagnosis isn't just label and move on. It's a condition that requires structured follow-up, mainly using beta hCG trends. Fast clinical differences. Clinically, keep it simple. Complete mole usually means no fetus, and beta hCG can be very high, so symptoms may be more dramatic. Partial mole may have fetal tissue, the beta hCG elevation is less dramatic, and it can mimic an abortion, which is a classic trap. So when you see first trimester bleeding, correlate ultrasound and hCG and confirm on pathology. Ultrasound patterns. Ultrasound gives you quick pattern recognition. A complete mole often shows a diffuse echogenic pattern, the classic snowstorm, with no fetal parts. A partial mole more often shows an abnormal placenta and may show a gestational sac or fetal elements. Don't memorize fancy imaging terms. Just link the pattern to complete equals diffuse abnormal tissue, partial equals mixed gestational findings. Genetics, exam favorite. Now the exam favorite, genetics. Complete mole is typically androgenetic diploid, commonly 46XX and sometimes 46XY, with absence of maternal genome. Partial mole is usually triploid, like 69XXY or 69XXX, with maternal plus paternal contribution. This genetic difference is exactly why the p57 stain becomes such a powerful discriminator. Gross concept, illustrated. Grossly, the mental image is grape-like vesicles. In complete mole, the vesicles tend to be diffuse and more striking. In partial mole, the gross appearance can be mixed and sometimes subtle, because there may be a mixture of abnormal villi and other gestational tissue. But remember, gross appearance supports. It does not replace microscopy and ancillary testing. Histology, what you see. Microscopy is where the diagnosis becomes real. Complete mole shows diffuse hydropic swelling of villi with more circumferential trophoblastic proliferation, and typically no fetal tissue. Partial mole shows changes that are more patchy. Villi can be scalloped. Trophoblast proliferation is usually mild and focal, and fetal tissue or fetal RBCs may be present. That diffuse versus patchy idea is a great exam anchor. p57 immunostain. When morphology is equivocal, p57 is the key. p57 is maternally expressed. So in a complete mole, where maternal genome is absent, p57 is negative. In a partial mole, maternal genome is present, so p57 is positive, and normal non-molar placental tissue is also p57 positive. One line to remember: complete equals p57 negative. Partial equals p57 positive. Risk of persistent GTD. This distinction matters because the risks are different. Complete moles have a higher risk of persistent GTD, roughly 15 to 20%. Partial moles have a lower risk, roughly 1 to 5%. So if a STEM says complete mole, your brain should immediately add stricter surveillance. Beta hCG follow-up. Follow-up is trend-based. After evacuation, beta hCG should fall to undetectable. Persistent GTD is suspected if beta hCG plateaus, rises, or remains persistently positive. This is why exams emphasize weekly until negative, then monthly per protocol, and contraception during surveillance, because a new pregnancy can confuse hCG interpretation. Do not skip the lungs. Don't forget the lungs. In GTD, The lungs are a key site to evaluate, so chest imaging becomes an important part of workup when indicated. And here's the exam pearl. Choriocarcinoma is highly malignant but classically chemosensitive, so early detection through follow-up and staging changes outcomes dramatically. One slide recap. Final recap in one slide. Complete mole, fetus absent, beta hCG very high, diffuse hydropic villi, circumferential trophoblast, p57 negative, and higher persistent GTD risk. Partial mole, fetal tissue may be present, beta hCG, less dramatic, patchy/scalloped villi, focal mild trophoblast, p57 positive, and lower risk. If you want, next we'll cover invasive mole versus choriocarcinoma with an hCG-based approach.